I warmly welcome all of you to today's CME on the maternal canvas, navigating the dermatological landscape of pregnancy. As we all know that pregnancy is a physiological condition associated with many hormonal, immunological, and metabolic changes. These changes range from mild changes, transient changes, to changes that can significantly affect the maternal comfort as well as fetal well-being. So now I'll be welcoming Dr. Fouzia Yeasmin ma'am, Assistant Professor, Department of Dermatology and Venereology, to discuss today's topic.
Respected senior, junior, and dear colleagues, I am Dr. Fouzia Yeasmin, Assistant Professor, Department of Dermatology and Venereology. Today I will be discussing the topics about the maternal canvas, navigating the dermatological landscape of pregnancy. As we all know that pregnancy is a unique physiological state where dramatic, hormonal, immunological, and metabolic changes can occur. As most of the changes are benign, but in some dermatological conditions that are unique to pregnancy can cause significant maternal discomfort, anxiety, and in certain cases fatal risks. Today I will be discussing some pregnancy related or pregnancy specific dermatoses that every clinician should be able to recognize early, differentiate correctly, and manage promptly. My focus will be on early recognition and maternal fetal implication and early diagnosis. Pregnancy dermatosis, a puzzle within a physiological storm. Pregnancy transforms nearly every organ system. The skin is no exception. But when do these changes cross the line from physiological to pathological? Why do some women develop intense pruritus, blistering eruptions, or widespread rashes? The immune system shifts, hormone surge, and metabolism rears itself. Amid these storms, the skin becomes a canvas of clues. But which clues signal danger and which are simply noise? Some eruptions cause only discomfort, while others may lead to complications. Recognizing patterns early is a clinician's critical diagnostic puzzle. The pregnancy dermatosis leads to physiological changes associated with pregnancy, pre-existing dermatosis affected by pregnancy, and dermatosis specific to pregnancy. Some physiological changes that occurs in pregnancy: pigmentation, vascular, structural, hair and nail. Pigmentary changes mainly melasma, hyperpigmentation around the areola, linea nigra on abdomen, and darkening of nevi. And the vascular changes that occurs mainly spider angioma, palmar erythema, varicosities, non-fitting edema, and pyogenic granuloma. Here there is a picture of structural changes showing the stria gravidarum. Stria gravidarum, the most common structural changes in pregnancy, also known as stria gravidarum. And some hair changes which include thickening of scalp hair, hypertrichosis due to prolongation of the anagen phase, and androgenetic alopecia. And some nail changes that includes onycholysis, brittleness, subungual hyperkeratosis, and transverse grooving. And second, the disease potentially worsen during pregnancy is infectious, immunomediated disease, and metabolic diseases. Infections include candida, vaginitis, trichomoniasis, wart, herpes simplex infection, and leprosy. Immunomediated diseases which worsen during pregnancy may be systemic lupus erythematosus, and metabolic diseases include diabetes mellitus and thyroid disorder. And now I will be discussing the well-defined dermatosis associated with pregnancy that includes: number 1, pruritic urticarial papule and plaque of pregnancy, which is most common; prurigo gravidarum, also known as atopic eruption of pregnancy; recurrent cholestasis of pregnancy; impetigo herpetiformis, also known as pustular psoriasis in pregnancy, that is life-threatening; and pemphigoid gestationis or herpes gestationis. Here some interesting cases we usually treat in our outpatient department, dermatology outpatient department. The picture showing pruritic arterial plaque mainly occurs in the stria, which usually start in stria. A 27 years old primary cavida at 36 weeks of gestation. Patient presented with erythematous papule and plaques over the abdomen for 2 weeks, severe itching for 2 weeks, and there is no prior history of atopy or drug intake. On examination, we show that on palpation, multiple swollen papules and plaques with raised local temperature and mild tenderness over the abdomen. No vesicle and bulla or mucosal involvement, and other systemic examination reveal normal. And we treated her with, firstly we counsel her, then the medication we prescribed, the antihistamine, that is tablet cetirizine, and the potent steroid, and the moisturizer. And now there is case 2, the picture showing multiple pruritic papular lesion present mainly over the abdomen, arm, and lower extremity. A 26 years old multiparous female at her 23rd weeks of gestation. Patient presented with multiple papules over the abdomen, hands and legs for 15 days, and patient complains of severe itching worsened at night for 15 days, and she has a previous history of atopy. On palpation, multiple small discrete firm erythematous papules over the abdomen and limbs with few excoriation marks. Other systemic examination was normal, and we do have investigation normal CBC, serum IgE, ALT, and ALT. And we treated her with, first we counseled the patient, then the medication prescribed, the antihistamine, which includes levhydrolene and ointment clobetasol, and moisturizer, which include light liquid paraffin. So my provisional diagnosis is prurigo gravidarum, which is also known as atopic eruption of pregnancy. Now the case 3, here the picture showing multiple excoriation present mainly over the lower extremity. A 28 years old primary gravida at 32 weeks of pregnancy presented with intense generalized itching for 10 days. Itching is more pronounced over the palm and sole. No specific skin lesions or only excoriation mark present. We do have investigation, total bile acid, ALT and AST, gamma glutamate transferase, and bilirubin. And my provisional diagnosis is intrahepatic cholestasis of pregnancy, and we treated the patient with ursodeoxycholic acid, antihistamine, and planning of early delivery. And the intrahepatic cholestasis of pregnancy can lead to fetal stillbirth, preterm labor, and meconium aspiration. And here the picture showing some pustule on an erythematous base, and this case is known as impetigo herpetiformis, also known as pustular psoriasis in pregnancy. The onset is 3rd trimester. Presentation is called pustule on erythematous skin. Site of lesion mainly it start on flexular surface, then generalized spread. Fever and systemic toxicity present, and high maternal and fetal risk. And it requires urgent management. Confirmatory test is skin biopsy for histopathology, where we can found spongiform pustule of Fogg's, and a specific treatment is systemic corticosteroid, prednisolone 40 to 60 mg per day, then gradual tapering after the lesion resolves. And here is the picture that showing multiple tense bulla. It usually starts around the umbilicus, and it is autoimmunoblistering disease, appears mainly in 2nd or 3rd trimester, starts around the umbilicus. Patient present with severe itching and bulla, may recur in future pregnancy, and my provisional diagnosis is pemphigoid gestationis, which is also known as herpes gestationis or bullous pemphigoid in pregnancy. Risks. The risks involve preterm labor, low birth weight baby, and confirmatory test is skin biopsy for histopathology with DIS. In DIS, we can found linear CC deposition at basement membrane zone. And the treatment includes systemic corticosteroid and histamine and both dermatology and obstetric care. Now we come to the miscellaneous disorders which usually worsen during pregnancy. These include scabies, tinea infection, acne vulgaris, pruritic folliculitis in pregnancy, and drug reaction. There are several studies occur worldwide which shows the pregnancy-related dermatosis. In this study, we mainly found the pruritic articarial papulum plaque of pregnancy is mostly common, and the intrahepatic cholestasis of pregnancy is life-threatening and can recur in subsequent pregnancies. And we are also doing some study in our department with collaborating with others. Now we come to the most interesting topic, the myths versus facts. Number one, the pregnancy glow. The myth is every pregnant woman gets a radiant pregnancy glow. But the fact is the glow is a real phenomena caused by increased blood flow and oil production, but it doesn't happen to everyone. Many women experience acne, dryness or melasma instead. Number two, the itching. Itching is a normal, harmless part of every pregnancy and can be ignored. This is myth, but the fact is, while mild itching from stressing skin is common, severe itching, especially on the palm and sole of the feet, can be a symptom of a serious liver condition called intrahepatic cholestasis of pregnancy, which requires medical attention. Number three is stress mark. The myth is expensive cream can completely prevent stress mark. But the fact is stress marks are largely due to genetics, skin types and rapid weight gain. Moisturizer can help with dryness and itchiness and keep the skin soft, but the marks typically fade on their own after delivery, though they may never disappear completely. And some skincare safety. The myth is all skincare products must be avoided during pregnancy to protect the baby. And the fact is many skincare ingredients are safe, such as azelaic acid, benzoyl peroxide and hyaluronic acid. However, certain ingredients like retinoids and hydroquinone should be strictly avoided. And the baby's gender. The myth is itchy skin can predict the baby's gender, but the fact is there is no medical evidence to support this. A baby's gender cannot be predicted by skin symptoms. And the condition severity. All pregnancy skin issues are benign and resolved after delivery. The fact is most are benign, but some conditions like intrahepatic cholestasis and painful gestation carry potential risks for the fetus, as for example the preterm birth, and requires close medical surveillance. Now we come to the take-home message. Physiological changes are common. Don't ignore intense itching. Blisters are a red flag. Most rashes are benign. Treatment requires caution. Distinguish between normal and pathological skin conditions. And diagnosis is key for management. Treatment prioritizes safety. Multidisciplinary care is essential. Patient education is crucial, and itching should be investigated. So pregnancy, enjoy every single moment without itch. And thank you so much for your attention.
Assalamu alaikum. Thanks to the Department of Dermatology for their nice presentation. আচ্ছা, আমি একটা ছোট্ট কথা বলতে চাচ্ছি। সেটা হলো যে আমাদের এক পরিচিত ডক্টর উনি, তো ওনার ইচিং হচ্ছিল ডিউরিং দি টাইম অফ করোনা। তো ওনার শাশুড়ি আম্মা বলতেছে, আমি তো পেপারে দেখলাম যে ইচিংটা প্রেগনেন্সিতে খুবই খারাপ, তো করোনা বলে যাওয়া আসা নিয়ে একটু দেরি হয়ে গেছে। তারপরে দেখা গেল দ্যাট ওয়াজ ইন্ট্রাহেপাটিক কোলেস্টেসিস অ্যান্ড দ্য বেবি হ্যাড আইইডি। তো অ্যাওয়ারনেস ইজ ভেরি ইম্পর্টেন্ট আই থিঙ্ক। তো এটা আসলে একটা বিরাট লস একটা ফ্যামিলির জন্য, অ্যাট দি এন্ড অফ দি প্রেগনেন্সি ফিটার লস। তো যাই হোক, তো অ্যাওয়ারনেসও দরকার আছে। তো সবাইকে ধন্যবাদ স্কিন ডিপার্টমেন্টে, ধন্যবাদ।